for postgraduates in pathology. This is the season 4. Today on 3rd of July, we are gathered here for the talk on about how to describe blood cells. This talk will be chaired by Dr. Manupdesh Singh. He's professor in Department of Hematology, PGI Chandigarh. Welcome, sir. The talk will be taken by the great faculty, Dr. P.G. Subramanian, sir. He is the professor and head of Department of Hematopathology and actor at Tata Memorial Center, Mumbai. I welcome you, sir. Today we have 9 students with us, Dr. Ariba, Dr. James from Jammu, Dr. Anuja Moore from GMC Assam, Dr. Prerna Prasad from Dehradun, Dr. Sanit Mani from AIMS Kalyani, Dr. Kusum from Behrampur, West Bengal, Dr. Suraj from Assam, Dr. Varshita from Dr. Chandrama Institute of Medical Education and Research, and Dr. Rujuta from Sangli. I welcome you all, students, and so myself, Dr. Sakshi Gupta, Assistant Professor in B. Barua Cancer Institute, Assam. Our moderator with my colleague, Dr. Bonita Bora. She's in consultant in a lab in Guwahati. The webinar is hosted by Center of Oncopathology by Dr. Anita Borges ma'am and Dr. Sumit Gujral sir. These are a few reminders. If you face any interruption in the connections or no sound or video is freezing, you can just leave the meeting and rejoin from the same link. I think there are no poll questions today and no annotations requests are required will be entertained in this class. However, I request you all to participate into the chat. You can type your queries and questions in the chat. These are a few disclaimers by the organizers. These are a few more disclaimers. The recordings will be made available till Sunday. For the upcoming slide seminar, we will have the approach to peripheral blood smear on the next Tuesday, and then next Thursday, there will be another. I hand over my present mic to Dr. P.G. Subramanian sir, please, and Dr. Manupdesh sir. Thank you, everyone, and please welcome the teachers.
So we will be starting this program. So this is meant to be an online reproduction of a case discussion in a multi-head microscope. So we want all the people to be interactive. So you might have it doesn't have any structured PPT or of that sort. So we will be going through. So initially I'll be trying to cover some normal cells which are there in the peripheral blood, then slowly move over to other peripheral smear. We will be having peripheral smears which are abnormal, and then we will move over to normal bone marrow towards the end of the session. So the main aim of this is to get comfortable in able to describe what we see in the smear, and then for the students to practice it as well as learn it, and to understand what are the problems when you try to describe a cell. So that is the main thing. So this doesn't have a structure as such. Most of the cell morphology I will be covering will be white cell, as we are an oncology center and we get very few, though red cell disorders, whatever is there in the smear, we might be able to say, but it will not be a structured red cell disorder sort of a stump. Most of the thing will be for the white cell. So with this, I will start with the so I'll start with the first slide. So this is a 10x view of the slide. So this is a peripheral smear. So this is not a marrow. And So when you look at it in 10x, can the students, try to give what they feel, what they can understand from what they are seeing in the 10x view? So I can start with the first student, Ariba.
It looks like a normochromic picture with
Now in
increased
10x, if you're going to say that, it will be major problem. So I've not gone into oil, so we'll come into that. Yeah. So predominantly, I do agree that your guess on 10x is normocytic, normochromic. But what I would want is what is the cell number or a cell cellularity when you're seeing it in 10x. See, one is the way you systematically write your report, but what you write your report may be little different from the way you look at the slide, the approach when you take a slide and start seeing it. So we will be trying to cover both ends. Yeah. So do you think it is it's a smear with a normal WBC count, low
No,
WBC count,
increased,
high WBC count?
looks like a smear of leukocytosis.
Can you just repeat it? I think I was not able to hear what you were saying.
Sir, increased in number. The leukocytes
Increased
are
in number.
increased.
Increased in number. Good. So that's a very, very good thing. So that's the first thing you will start picking up when you see when you start seeing a smear. Then the other thing when you see in low power is to see what is the distribution of the cell. So when you see here, this is the tail end. Okay. So you have a tail end of the smear where you are having increase in number of WBCs. So when we make a smear, the larger cells tend to go along with the smear at the end. And sometimes you may have uneven distribution. So this is important because when you try to judge your count, if there is uneven distribution, all the cells are here and very few WBCs this side, then you will have a problem of underestimating whether it is high count or low count. Okay. So next we will go into a 20x. So this is just a higher view. This is generally not used very commonly in hematology, but if you're a beginner, I would suggest if you have 20x in your microscope, you can use it. Otherwise, we go from 10x to straight 100. So we will look at it that way. 40x is also used, but 40x is a problem because we use oil in hematology. So many times the 40x gets spoiled by the oil coming in contact with the 40x. So what are the cells looking similar or are they looking different? Predominant cells.
So the predominant cells are neutrophils.
Yeah.
With the WBC.
So why did you conclude they are a neutrophil?
The multilobated nuclei and the cytoplasm is granular.
Yeah. Okay. So, but granular or not, can it be eosinophils? They will also be multilobate nucleus.
Yes.
So we will now try to confirm that by going into oil. So what do you think this cell is? So why do you say it is neutrophil? Say suppose I say it is eosinophil.
So the eosinophils are mostly bilobated and they have reddish granules.
But does it mean that a neutrophil nucleus cannot be having 4 lobes? See, the classic description is what you are saying is correct. It is bilobed generally. But what is the distinguishing feature between a neutrophil and an eosinophil?
The granules are more coarser and
yeah. So if you were going to describe this as a cell, So generally the cell description follows some sort of a system like size, shape, then cytoplasmic content, then nuclear shape, nuclear content, then inclusion. So this is the way we try to go through a cell, which is if you are trying to describe. So this cell, in hematology, most of these cells are round to oval. So the shape rarely is a distinguishing feature. More important distinguishing features are size, then the nuclear shape. So in this, that nuclear shape which you have taken is, you have said it is a lobated nuclei, but you are saying that it is neutrophil. So why do you say a neutrophil it is? So one, you said eosinophil is coarser granule. Suppose I say that there are coarser granules in this. How will you decide what is coarse, what is fine? No, not microscope. The power supply is going. Microscope power supply is going. That's a camera. There is no light here. Yes, sir.
Is I audible?
Yeah,
Yes, sir, we can
Yes,
hear
sir.
you.
we can hear you. I'm just.
We cannot see you, sir. We cannot see the screen.
Light is there. Yeah.
Now, sir,
Now,
visible. Your slide is visible now, sir. Now it's fine,
Yeah.
sir.
Yeah. Oh, sorry. Okay. So there was a hiccup here. There was a loose contact in the power supply for the microscope. So, yeah. So we were saying, like, how do you decide whether this is granule is fine or coarse? So any of you can try to explain it in your words. What do you mean by fine and coarse? Any of the students?
Anuja, can you describe? Dr. Anuja?
Ma'am, if the granules are coarse, it will obliterate the nuclear features.
Dr. Suraj?
So that may not be obliterating nuclear feature, may not be the reason why we call it coarse. Actually, it is the size of the individual granules. So if you are not able to appreciate, so I have just increased the light a bit, and if you start looking at it, I am just adjusting the fine focus, because this granule coarseness will not be evident in a single focus. So generally when you try to adjust the fine focus and see it, you will start having, you are having the granules here. On the other hand, some granules are having a color, say, which is closer to the red cell cytoplasm color, whereas the other granules are having a color closer to the nuclear color, if you look at it. So which of them is the neutrophil granule and which is which granule? So
Dr. Varshita, your first year, can you describe?
Yes, ma'am. Hello, ma'am, am I audible? Sir, am I audible?
Yeah, you are audible. Sorry.
In the chat, sir, somebody is writing primary is azurophilic.
Primary is azurophilic. So what do you mean by azurophilic? Which color would azurophilic be? Any of the students? So it's a very common problem. Most of us remember the words but are not able to convert the words into what we see.
Blue.
So the ones which are having a color which is closer to the nuclear color.
Nucleus.
They are the ones which are called azerophilic. They are the primary granules. So your myeloperoxidase is in the azerophilic granules. The one which is closer to the red cell cytoplasm, it is vaguely seen. There are areas where the granulation is light and it appears white. And there are where those granules are denser and it looks little more muddy or more like the more closer, if I am saying in this picture, to the red cell cytoplasm. So that is your neutrophilic granule. So that is what we call as the secondary granules or the neutrophilic granules. So that is the color of a neutrophilic granule. Now we go to the next cell. So is the cell in focus?
Yes, sir.
Yes, sir. Yes, sir.
So, Dr. Kusum, how would you say go about telling what the cell is? First, describe the cell and then try to say what it is.
Nucleus is round and cell size is same and
So everybody would agree
there
that
is
nucleus is round,
little bit indented.
Yeah,
indented, correct?
indeed.
Yes, or the cytoplasm, there is no granules in cytoplasm. Moderate amount of cytoplasm.
Correct.
And so
The chromatin is
maybe
coarse.
coarse, and there is no nucleoli.
Yeah, you can say there is no nucleoli, but maybe this area, if I point out, would you consider it as a nucleoli? This round circular area, which is lighter than the rest of the, with a very dark halo around.
So maybe it's nucleoli.
Yeah. It
And
is an
coarse
inconspicuous nucleoli. It is not
nucleoli.
it's not a conspicuous nucleoli. It is an inconspicuous nucleoli. Conspicuous
Yes.
nucleoli means you are able to easily make out the nucleoli. In this, it's a little difficult, not very easy to make out. Yeah.
Maybe lymphocyte.
Yeah. So can we go a little more into which kind of lymphocyte it is? Morphologically, how many kinds of lymphocytes are there? I'm not asking about BP, though they are immunophenotypic, but morphologically, what kind of lymphocytes are there?
Large lymphocyte and small lymphocytes.
Correct. So is this a large or a small lymphocyte?
Large lymphocytes.
It's a large, yeah, it's a more likely large lymphocyte. It has very less granules, but generally large lymphocytes are considered as large granular lymphocytes. Okay. So Manu, you want to add anything?
Right. So far, I would suggest
Yeah,
there
Manu,
is
I think.
my
Yeah.
voice. Yeah. So
Yeah, now your
is
voice is
breaking.
breaking. Voice is breaking.
Should be connected well. Okay, so I'm audible now.
Okay. I think we are not having good connection with Manu. So this would be considered a more of a large lymphocyte. And now let us go more and more into. So these are all which kind of cells?
Neutrophils. Neutrophils.
Neutrophils.
Yeah, correct. So neutrophils, once you have identified neutrophils, what all would you like to look in a neutrophil?
The number of lobes.
Number of lobes.
So are these neutrophils having normal number of lobes, less or more?
More. More.
Okay. So more number of lobes in a neutrophil is commonly seen in condition.
Vitamin B deficiency.
Megaloblastic.
Yeah.
Megaloblastic
Yes.
anemia.
Megaloblastic
Megaloblastic anemia. Correct.
Hypersegmented neutrophil.
Hypersegmented neutrophil.
Yeah. Okay. So this is from a patient who is on chemotherapy. So megaloblastic change is expected in that. Okay. So this again is another, how would you describe this cell?
Dr. Prerna,
Uh,
can you answer?
So this looks like a small. Looks like a small lymphocyte, and I describe it as a
why
small
did
to
you decide it
intermediate
as small?
size.
Why did you decide it as a small?
The size is smaller.
As compared to?
The previous larger lymphocyte we saw, and the cytoplasm is lesser in amount.
So one of the things which I would like to highlight is that when you say small, the small lymphocyte always is compared with the red cell. So is this
Red
as size close to the red cell, or it is far bigger than the red cell?
cell. Slightly bigger than the red cells that are around it.
Yeah.
The
Second,
nucleus.
small lymphocytes generally will have very low, very small
Cytoplasm.
amount of cytoplasm, and in this the cytoplasm is all round. If you look at the
Yes, sir.
nucleus, all the entire the nucleus is oval, and it also is showing some areas which look like nucleoli, like here, then this area. Okay, so inconspicuous
Yes.
nucleoli, and you are having an oval shaped cells.
Yes, sir.
Yeah, Manu, in case your connection is better, then you can join in.
Okay, am I audible?
No, sir, the voice is breaking.
Otherwise,
No, sir. Meanwhile, Mani sir, there is a question in the chat box. Somebody is asking, increase in granules and toxic granules are same thing or not?
So that I will come to. So first let us understand what are the type of granules, then I will go into that.
Yes.
So this is, in this is a very thin area. So are you able to appreciate the secondary granules better in this? See, you have one here, another one here. There is an empty space, these white areas. Then you have cluster of granules here. In between, you are having very faint, fine granules which have color similar to the nucleus. Okay, so these granules which are here in this area, here there is thinning of granules. There is more granule here, more granule here. There is granule on this edge, but in the center there is areas which is granule free. Okay, so these granules are what is called as the secondary granules, whose color is more closer to the red cell, and the purple one is the one which is having a color closer to the nuclear stain is called as the primary granule. So now we will come to the next in this. In this, when you look at it, previously there were areas where the granule was little bit thinned out. In this, it's nearly packed more uniformly with granules, the same sort of granules. Okay, so toxic granule also I'll be covering. When I get one cell which is nicely showing it, I'll bring it out. So toxic granules generally are the primary granules. When the primary granules are very evident than the secondary granules, that is when you call it as a toxic granulation. Okay.
So can you repeat?
So I said there are two kinds of granules, primary and secondary. So when primary granules become very prominent, that is called as a toxic granulation. So primary granules are which kind of granules? Any of you can answer that?
Azurophilic.
Azurophilic. And they have a color similar to?
Nucleus of
Nucleus.
So they have a color similar to nucleus. So that is where it is called as an azurophilic granule. And that azurophilic granule, when it is prominent, then it is called as a toxic granulation. So when these granules are lost, the neutrophil cytoplasm starts fully appearing like this white spaces. Then that is what is called as a hypogranulation. Okay. So hypogranulation is generally seen in which conditions? Anybody?
Acute anomaly.
Yes. Yeah. And now a little bit of red cell. So this cell, what is it?
Teardrop.
Teardrop
Cells.
Teardrop cells.
Yeah. Yeah. So when you look at it, you are having red cells. What is the difference between this red cell versus this red cell and this red cell?
central pallor is more
Highlight.
visible.
Hypochromia.
Chromasia.
Yeah. So why is the central pallor lost in these two cells? So when a central pallor is lost, what do you call them? Spherocytes. Yeah. So spherocytes, you call them as spherocytes. So spherocytes, does most common cause of seeing spherocytes is what in routine practice?
Transfusion.
So which are the causes? One you will say is hereditary spherocytosis. Other than that,
Hereditary spherocytosis.
other than hereditary spherocytosis, which are the conditions you end up seeing spherocytes?
Autoimmune hemolytic anemia.
So what is the hereditary spherocytes and autoimmune hemolytic anemia spherocytes similar, or are they different? So in autoimmune hemolytic anemia, you will get microspherocytes. In this, the spherocytes are similar in size to the rest of the red cells. If it's a smaller cell, because in autoimmune hemolytic anemia, the red cell loses its membrane. So its membrane gets smaller, so the red cell gets smaller. So the microspherocytes are more common in autoimmune hemolytic anemia. In hereditary spherocytosis, this will be there. But is this a case of hereditary spherocytosis if you are seeing spherocytes?
No.
So how do you differentiate one from the other? So in this, there are only few spherocyte cells. So in hereditary, predominant cell is very likely to be spherocytic. Few spherocytes are generally seen in most common reason why you see them is either you have gone into the very thin area of the smear, but this doesn't look to be that thin an area because the RBCs are not very far off. Say if you go to the very end of the smear, then you will see everything has lost central pallor. So this is not spherocyte. But if you see them in the interior where you are seeing spherocytes mixed with cells with loss of central pallor, then the first thing you have to think of is whether the patient has received a transfusion. Okay. So these are transfused cells for a short while. If the smear is made very soon after a transfusion has been received, you will start getting spherocytes. Okay.
every
Manu, you are trying to say something?
I think sir आपका mic में कुछ issue है, the device. You can use a microphone maybe.
I'll just try to switch over.
Now it is
Yeah,
good,
now
sir.
Okay, so what it was that there is sort of an area you actually give which money for the is it's not at the tail end and not usually in the and there the area you describe most of it is including the red cells. Now he's actually touched that part. They usually describe basically that area is where the
Sir, we
RBC
can't hear you.
okay
Voice
again.
is breaking, sir.
Okay. Let Mani continue. Let's over to probably some other device.
okay. So when till the time Manu rejoins from the other device, we will move a little more into. So let us go. Most of it is neutrophil. So let us look for something which is little different. So you got this. What would you call this cell as? So Dr. Rituja.
So
Anybody?
cell is larger in size,
Yeah.
And
multi-lobe,
Yeah.
and clumped dense chromatin is seen.
Yeah.
Pale pink granules are
What about
seen.
granules? Granules.
Pale pink granules.
So why do you think it is pale pink
Secondary granules.
So let me write. I'm just shifting from this cell. Is the granule similar to this?
yeah, Ariba, can you tell?
Sir, I think
Or
that's
is it different from? Is the cytoplasm similar to the previous neutrophil or is it different? Sorry.
it is different.
Different, sir.
So what is the difference in the cytoplasm between that and this?
Actually,
Grayish
no
blue
granules are seen
cytoplasm.
in this one.
Yeah, so no granules are seen. Correct.
A granular side.
Granular cytoplasm.
It is having more of a bluish type of cytoplasm.
Yeah, you can call it bluish, but
Grayish.
yeah, I mean, yeah, adjective, whichever you use, some are textbook adjectives which may not actually match what you're seeing, but yeah, it's okay. Or some people will say it is grayish, that's okay. So so what is the difference in this cytoplasm versus this? So now I brought both into the same field. So one is looking more muddier than the other.
Yes.
Yes, sir.
Correct?
Yes, sir. Yes, sir.
So This is a neutrophil with a cytoplasm of a neutrophil. So what is this cell then?
So monocyte.
Yeah,
Oocyte.
it is a monocyte. So monocytes can also have lobated nuclei. Though classical textbook picture, you will put some kidney-shaped nuclei. So monocytes can have lobated nuclei. Now look at the chromatin of the nucleus in the neutrophil versus this. Are you able to put in words what you are noticing as the difference?
In
Monocyte
neutrophil,
has
it is
a
slightly
comparatively more
clumping of
open.
chromatin in neutrophil.
So why do you see? Yeah, people use word open chromatin, but what do you mean by chromatin is open?
Dense chromatin.
Active. It looks
No clumps, no clumping of
transcriptionally
chromatin.
active.
Yeah. So which is clump? This or this?
The neutrophil one.
Neutrophil.
Neutrophil is showing clumped chromatin. Yeah. Whereas what is the chromatin difference here altogether? Neutrophil is showing clumped chromatin because there are white areas, there are very dark areas, there are intermediate areas, and here there are areas in which the light is just going through plain transparent, and you are having very dark areas where no light is going through. So that is why it is not having a uniform chromatin staining. Whereas in this, what is there?
Chromatic.
Uniform staining throughout
So whether I look at
the
this
nucleus.
end or this end or this end, the density of the material looks more or less the same. Slight differences are there, that will be there, that's a any biological will have, but more or less they are the same density throughout the nucleus. So this is one of the very important feature for a monocyte. Okay, many times the cytoplasm, the lobulation, all of them can mislead you, but this is a very important feature to keep in mind for monocytes.
Sir, there is a doubt in chat. Is cytoplasmic vacuolation always found in monocytes?
It may be found, may not be found. Cytoplasmic vacuolation can come in neutrophils also, especially if it is smear is made from a stored sample. So vacuolation is a finding, but it is not going to help you to identify every time what the cell is. It might help in a monocyte, but in other places it can mislead you.
Yes.
So, am I audible now with
Yeah,
using
now
a
you are
cell?
loud.
Yes.
I'm using a mobile now.
Yeah.
Okay. So I was sorry, I interrupt in between money now. But what I wanted to say was that when money focused at low power, there is an area of the slide which you choose for giving your morphological whatever you want to see descriptions is generally a little away from the tail end, and you don't reach the most denser area. So generally, the area is where the RBCs sort of are closer, but generally don't overlap to each other too much. So that's a sort of correct area where Dr. Mani eventually, when he started describing RBCs, he exactly was describing the areas where you want to see rather spherocytes and area cells. Otherwise, you might have artifacts also in the other side. So that was one thing which I was wanting to point out.
You actually pointed out a very important thing which I missed. So so the current field which is there, is it an ideal field or a non-ideal field? If the students say anything.
Non-ideal.
Why?
The non-ideal
If it is not ideal, then why? What's the reason? What is the reason?
RBCs are sticking to each other, on top of each other.
Correct. So ideally the RBCs should be very well spread. So that is the zone of morphology what Manu was just emphasizing, and it's very important to be remembering that when you see the smears. Otherwise you can misidentify things because you looked in the wrong place. Yeah.
So there should be minimal
Manu, anything
overlap.
else?
Yeah.
Yeah.
The second thing I was out at that time was that there might be mild variations in staining depending what kind of Romanovsky stain you use. So most
Correct.
commonly used is Leishman. It's probably cheaper and easily doable. But if you use combinations of Romanovsky stains like May Grunwald Ginza combinations or Wright with Field or various other combinations, because sometimes it can gives a different picture to granules, there might be little shifts in the texture of granules and other things. So that's just two things which I initially wanted to point out at the start and continue, right?
Color can change a little bit based on which Romanowski, what he was trying to say is colors can change based on little bit on the based on the Romanowski stain which you use, as well as the stain standardization in your lab. So that is one thing. But if you try, just keep in mind only the color, then if the stain changes, you will have difficulty in identifying. So you have to keep all the features in mind, the texture, the density. So previously somebody was asking about the toxic granule. So there are two neutrophils in this. So in this neutrophil, if you look at it, I'm just fine focusing it.
Sir,
So when you fine
your
focus,
screen is not visible.
my screen is not visible.
I think you have to again start presenting.
Share. You're not in
Share
share
screen,
mode.
okay. Okay, I think my share mode must have gone. Ah, yes.
Yeah, now it is visible, sir.
Yeah. So now it is visible. So there are two neutrophils here. So one is this, one is this. Can anybody say what is different between these two? I'm just moving the
Number
fine
of
focus a little
primary
bit.
granules.
Dr. Sanith, can you tell?
Correct.
Yes, madam. In the
Granules.
Yeah.
left-hand side, I can see the neutrophil.
Yeah.
The granules are more of like five
Ah.
type of granules. And in the right-hand side, the neutrophil, the granules are looking more coarser and maybe toxic type of granules are there.
It is, yeah, I won't say fine here. So because it's granule nature is the same in between. Sorry. Yeah. In both. What is there is in this one, the granule density is a little less. In this, it is more
Comparatively
denser,
less.
even the secondary. Yeah. And on the other hand, you are having many of those purplish kind of granules, which are more in number here than, though they are here, if you see a few of them are there, but they are less in number here. So when this gets very more and more dense, that is when you call it as a toxic granulation. This purple granules, the
Toxic
ones
granule.
here, yeah. So that is what we call as a toxic granule. There is a second issue here, which is in the red cell. It is, so how many of you are familiar with what is a water artifact?
Anuja, can
Any
you
of the
tell?
register?
James?
When the smear has not been dried properly and air dried properly.
Okay. Can you add, Varshita? Can you add anything?
No, ma'am, I'm not familiar with water artifacts.
Ariba, can you add?
No, ma'am.
Ma'am, here we can see a few water bubbles. The percentage of water is more.
Okay.
Okay, so a water artifact has nothing to do with drying. But what happens is we use Wright stain, which is very similar to Leishman stain. So in the Leishman stain, the first 2 minutes you use the pure stain. So pure stain is generally made in methanol. So that methanol 2 minutes is required for fixation, and it is made in absolute methanol, not 75%, not 90%. It is 100% methanol. So whenever the methanol gets absorbs water. So especially we are in Bombay where it is monsoon season, humidity is high. So if somebody keeps the stain open, the moisture in the atmosphere goes into the pure stain, and that will increase the water content, and it will reduce it from absolute methanol to say 99.5% methanol or 99% methanol. So when that methanol is getting diluted, that is why it is called as water artifact. It is water getting into methanol. You identify it as the central pallor will have a very sharp border. In this, there is so much that even the outside the red cell membranes have started getting ragged look. So this sharp border is not a pallor, and sometimes the central pallor is taken as hypochromia by many of these students. So that is not the right way. So this is not a good smear to interpret the pallor, because the borders in the center, if you look at it, this is a sharp border. I'll take you to a normal central pallor in a thinner area. Okay. So in this also, if you see, many of them are having very sharp border in the central pallor. So these are all things due to the water artifact per se. So a normal red cell with a very well stained red cell shouldn't have this sharp border. It should have a fading border in the central pallor. So I'll just move into a better area. So this is one of the common reasons why in this case, this smear, there is actually very heavy water artifact that it precludes. So a normal central pallor should be like this. See, it is just diffusing into the center. It's not sharp like here. So these sharp pallors are all result of water artifact. It is sometimes very difficult if you live in a humid climate and if you don't have a sealed bottle for your stain. So this is a very common artifact which is there in almost all the labs wherever I have seen. So this is something you have to keep in mind, especially when you are judging your hypochromia. Now, next, Dr. Janus, can you describe what this cell is?
This is a large cell with a single lobed nucleus with cytoplasm containing abundant cytoplasm with some fine granules.
So which kind of granules are they?
It looks like both primary and secondary.
So secondary is of which cell?
Neutrophil.
Yeah. But is it a neutrophil?
No, sir. It's a precursor for neutrophil.
What is its size also? In this, the size is important. It's pretty large cell. You can include 3 red cells into that.
Yes, sir.
So
probably a myelocyte.
Is there in the nucleus, is there any nucleolus?
There are light areas, sir, too.
But no prominent nucleolus.
No prominent nucleolus.
So what in
Myelocyte.
precursor in which stage? Myelocyte. So why not a metamyelocyte?
Metamyelocyte has more of an indented nucleus.
Yeah. Okay. Yeah. Okay. This doesn't have an indentation, so you will count it as a myelocyte. Good.
Myelocyte.
So let me look for a Manu. Are you there?
Yes, I'm very much there. I see
now
it's an
you're
interesting
audible.
smear
So-
you are showing. They are factual findings, but I like you actually to spend a minute or so on platelets also. They look interesting. Many are normal, some are. Yeah.
Okay. Yeah, I think I'll go into the oil for that. So platelets are very difficult unless you go into the oil. So I think this would be fine, Manu. So if you look at it, there are platelets like this, and there are varying size from this small to this big, and there are some things like this also. So what is the difference between this as well as this?
Granularity.
Giant platelet.
Yeah, granularity. Yeah, this has lost the granules. This is not. So giant platelet, you said. So a giant platelet has a clear definition. So how would you define a giant platelet?
Dr. Sanit, can you answer?
Giant platelet will have the size almost comparable to the size of an RBC.
Okay. And what is
Larger
that?
the size of RBC.
Yeah. So Manu, you agree with it?
7 to 8
Sir, in
micrometers.
the chat, what is the best multiplication factor in platelet number calculation under oil fields? There is a question in the chat.
Okay, that you will have to decide based on good sample from your lab, because the multiplication factor will vary based on your microscope's field of view. So not all microscopes have same field of view. Usually, if I remember correctly, 18 is the smallest one. The bigger ones like mine will have 22. So if the field of view is bigger, that means you are seeing more field. So in that, the platelet count factor changes. So you'll have to do an adjustment for that. So I think generally we use a high power field into 10,000 for small microscopes. Correct me if I'm wrong, Manu.
Yes, sir.
Yes, sir.
Yeah, that's true. 10,000 mostly in your, that's for platelet, oil field.
Yeah.
And I think that's the most commonly used for the microscope, but definitely it would vary depending on your lens, the area you are seeing under the lens. So you'll find different figures in text also because of that. And that question is valid because people do see or Google or whatever, and they find figures varying from 10,000 to 15,000 to somewhere there. But I think most of us do use 10,000 in our microscopes, Olympus, Nikon, or Leica, or even Zeiss.
Sir, there is a division in chat about the giant platelet size discussion. Some are asking, is it a size of microsite? Some are saying 6 micrometers. Some are saying 3 micrometers for a giant platelet.
7 to 8 micrometers.
Okay, so let Mani point it out, but I would you generally take around the size of normal RBCs, that big. Otherwise, just large platelets. Giant when it reaches something there, RBC size. If Mani agrees, that would be okay.
Yeah, I agree. Now coming to this cell again. So I think Dr. Prerna can take this.
So this looks like a large cell
Uh.
with round to convoluted nuclei and deep basophilic cytoplasm. There are no granules present. It looks like a monocyte.
Yeah, monocyte, correct. So this one, anybody? Anuja?
Ariba,
Lymphocyte.
Anuja, Ariba.
Yeah,
Oh.
Ariba.
Anybody? Kusum?
Sir, it looked like a lymphocyte.
Reactive lymphocytes.
React.
So yeah.
Anybody?
So why do you call it as reactive lymphocyte, and which kind, small or large?
Oh,
Uh,
small,
Small lymphocyte.
small mature lymphocytes.
why do you call it small? Because I had said earlier that when we call it small.
So,
React like showing one or two prominent inconspicuous nuclei is also there.
Yeah, correct.
Some mild to moderate cytoplasm.
So this,
So
yeah,
reactive
if I do a fine focusing, there might be one or two granules around here. I will use the arrow. You can see here. So this is also an LGL. Sometimes its nucleus can be a little bit convoluted. So large granular lymphocyte, this is. So
somebody
now,
is asking, sir, why can't the previous cell be a reactive lymphocyte as well? The previous, which she called monocyte.
yeah, a reactive. The reason I'm saying is that reactive lymphocyte, even normal lymphocyte can be reactive lymphocyte. So when you say reactive, it doesn't have a specific morphology. People use it when there is a lymphocytosis to say that it is reactive lymphocytes when they see an LGL proliferation. But LGL proliferation will be common in many viral infections. So that is why they call the lymphocytosis at that time as reactive.
Reactive. And what is it activated?
Reactive, activated are roughly similar because there are very not very clear definitions on this. So Manu, I think you want to come in on this?
I think they are similar only because activation does occur
Yeah.
when the lymphocyte is exposed to some sort of stimulus. You sort of may try and hair split the things, but I believe you need to take them as similar things: activation versus reactive lymphocyte, activated versus reactive.
Yeah.
So isn't this specific for viral exposure, activated lymphocyte, or it is not like that?
Activated lymphocytes are not, it can be in inflammatory conditions also. You can see it may not be specific for viral alone. Only just says that there is some kind of an inflammation. It could be virus induced, some other reaction, sometimes LGL proliferations. All these will come in. Yeah. So people, now this is what you would call as a textbook picture. Correct? Most of you will call this only this, something like this, as a monocyte. You have the kidney shape, nucleus, indentation, everything. Okay?
Yes, sir.
I think Dr. Suraj can describe. We are not audible. Dr. Suraj, you are not audible.
Okay. I think I was trying to hunt out a small lymphocyte in this, but I'm not getting any. So we will just move into the
next.
abnormal ones in terms of smear.
There is a question in the chat box, sir. What about large lymphocytes with dark basophilic cytoplasm, which we typically see in dengue? What do you call them?
Dengue, they are called, the similar one will come even in EBV with deep blue cytoplasm. They are the ones which we call something kind of a downy kind of a cell, which is more characteristic for a viral infection.
Can we use term virocyte, sir?
Many people use many terms, but I would try to minimize things which are standardized and which are, if I say the same thing, it will mean the same thing to everybody.
There is a doubt. Isn't there they have more cytoplasm and have irregular nucleus in reactive lympho? More cytoplasm and irregular nuclei.
Irregular nuclei can be seen in reactive conditions, abnormal. It's very difficult to go just based on the irregular nuclei to say it is one or the other. But main thing is, it is very important to see whether it's a small lymphocyte proliferation or a large lymphocyte proliferation. So this is a next smear. So I can start with the Kusum.
Yes.
So this is in low power. Okay.
Yes.
So what do you note?
Increase in number of WBC lymphocytes.
Correct. Yeah, it looks monomorphic population. That is more or less the cells look roughly similar. Okay. Yeah. So one or two interesting cells are there. So I'll just go into this. You might sometimes get cells in many conditions, one or two which will not be clearly having a textbook kind of a description anywhere. Sorry, I think this is one of them, but we'll still try to make out what it is.
This is also peripheral smear, sir.
It's a peripheral smear.
Rutuja, can you describe?
You see, it's maybe myeloblast type cell.
No, you're trying to reach the cell. So when rather I would go by finding what is it first. Small size cells, large size cells. What is it?
Large round cell.
The nuclear position is where? More or less central or towards one side? What is it?
Eccentric.
Yeah, it is maybe eccentric or maybe yes, because central nucleus we generally tend to use for things in which there is cytoplasm all round.
And open up chromatin.
And multiple nucleoli also. In this nucleoli is more clearly visible than in the previous. In previous one we were seeing it as in this there's 1, 2, 3. Okay.
Yes.
Then the cytoplasm is abundant. Correct?
Yes, sir.
Yes.
And what else are you seeing in the cytoplasm? Some basophilic granules are there.
Basophilic cytoplasm.
Yeah. And then anything else you are seeing in the cytoplasm other than the granules?
Vacuolation.
Yeah, vacuolation is also there.
Vacuolation,
Yeah. So this could be based on when you look at the chromatin texture, it is more or less uniform everywhere. Though the size shape has nothing to do with the what we carry in mind as a classical monocyte, but this will also be a monocytic series cell which will be there. The reason is it doesn't have any of the secondary granules to identify as any other lineage. And it has vacuoles, and some azerophilic granules can be seen even in monocytes. So that's why I just took it. It's this kind of a single cell is not going to make or break a diagnosis, and there is going to be disagreements between people what it is also. So, but generally, yeah, I would put it more in a monocyte macrophage category. Manu, what would you have? Do you agree or you have a difference of opinion?
I agree to that. I'll put it in monocyte, a little macrophage-like look, but that's his best, morphological interpretation of that single cell.
Okay. You are having something similar here. Now this is again second cell of similar nature. So now I am starting to have some second thoughts about what I made. So this one, how would you describe? Again, small cell or a large cell? Let me put it, I'll bring it into the center, sorry.
Yes, Prerna, please describe.
This looks like a large cell.
Yeah.
Large cell with round
Yeah.
oval nucleus and prominent 2 to 3 nuclei with deep blue cytoplasm, but also granules are present, few granules.
Yeah.
So it's like could be a myeloid precursor.
Which stage of a myeloid precursor?
Myelocyte.
Myelocyte. Yeah. So the difference between myelocyte and a promyelocyte is myelocytes generally won't have a nucleolus. In this, there is a prominent nucleoli, a couple of them. So promyelocyte would be a good bet. I am now beginning to think whether the last one would also have been a promyelocyte. So you are having this kind of cells here. So actually single cell can sometimes be tricky. Then you try to look for more cells of similar nature. So now let us come to the predominant population. What are you seeing in this predominant population? What do you feel? What are these cells which are there in large number?
Blasts.
Blast.
Blast.
Why not a lymphocyte, if I say so?
Larger in size.
One is larger in size.
Prominent nucleoli.
Prominent nucleoli.
Okay.
And very scant cytoplasm only at the
Scanty cytoplasm.
So don't go just by the chromatin. What is the nucleocytoplasmic ratio?
High.
So high nucleocytoplasmic ratio of a large cell with high nucleocytoplasmic ratio is more in favor of a blast.
Blast.
Okay. The lymphocytes which are shown, which are large, will not have a high nucleocytoplasmic ratio. They may be large in size, but they will not have a high nucleocytoplasmic ratio. Okay. So you are having these kind of big cells also. I'm talking about this. So very high nucleocytoplasmic ratio, and nucleus appears round, and in many of them it appears lobulated also. Okay. And in between you are having this this kind of promyelocytes. And you are having this kind of cell also. When you look at it, this, I mean, it's very easy to put this into this because these are present in large number, but is it really the same? Or is it little different?
Different, sir.
So what are the differences you're seeing between this cell and the adjacent blast? This is also a large cell.
The chromatin is
Nucleoli
not a
present.
small
More
cell.
cytoplasm is
Cytoplasm and more prominent nucleoli.
Yeah, nucleoli. So which lineage would you put this cell into?
Myeloid.
The nuclear chromatin of this, is it similar to these?
No,
Yes, sir.
No.
it's less
No,
so.
It's more condensed compared to the larger cell.
Yeah, this is a kind of chromatin which they call various descriptions, which they call sieve-like or some kind of lacy chromatin or stuff like that. So this also looks for me more closer to a monocytic kind of a cell. Okay, monocytoid cell. It could be monocyte, reactive monocyte, or monocyte precursor. But you are having predominantly presence of blast, and you are also having presence of these kind of cells. What are these?
Nucleated RBC.
Nucleated
Nucleated
RBCs.
Yeah. So the next question is a little bit more complex. What would you call this cell?
So please bring it in center.
Nucleus. It looks
I'll
like a
bring
bare
it center.
nucleus.
Small
lymphocyte.
lymphocyte.
Small
See,
lymphocyte.
when you say
Minute
bare
lymphocyte.
when you say bare nucleus, this is a bare nucleus. There is no cytoplasm anywhere, and it has become like water has got into the chromatin. It has spread out. So and it has ballooned. So this is what we would call as a bare nucleus. In this, if I do a fine focus, there is a little bit of cytoplasm here, and its shape is more or less maintained. Where would you put that cell into?
Small
This one.
lymphocyte.
Small mature lymphocyte.
Now, if you compare this cell with this RBC, the cell is bigger than, which is bigger, this cell or this RBC?
The small lymphocyte is
similar.
bigger.
The
Yeah.
WBC.
So that cell is bigger. Okay. So now
There is a doubt
to
by
do a little-
somebody about being them hematogone.
that's a good thought. So, but
This is a peripheral.
now the question comes: what is hematogone?
Precursor B lymphocyte.
Precursor B lymphocyte, correct. But can we identify them morphologically reliably?
Very difficult.
And in this case, would you call them hematogone with this kind of picture? Yeah, if I pick up one cell and say, yeah, you might call it hematogone, but in this picture, would we call them hematogone?
Yes, Dr. Sanit.
Ideally, not to call this as hematogon.
Okay.
Yeah.
In chat, somebody asked her about the indentation and notch. Is there any indentation or notch in these blasts?
There are blasts, but indentation notch doesn't have that kind of a morphological significance. Even normal lymphocytes can sometimes show you indentation. Now I want you to concentrate on this cell. I hunted for one, but I'm not getting a better one. So I'm showing you this. This is a thick area. I do understand. So what is this cell and this cell? Are they same or are they different? The two adjacent ones.
Different.
Why are they different?
Size is different.
Size
Difference in size
Size is different.
and the color of the nucleus.
and color.
Cytoplasm also.
Cytoplasm
The
is more
larger
in the
cell
larger
seems to
cell.
have a cytoplasm.
A nucleocytoplasmic ratio, is there any difference in both?
For the smaller cell, answer ratio is increased, and for the bigger cell, like not that much increase. So we can see some mild to moderate amount of cytoplasm.
Yeah. So this, the other major feature is the nuclear chromatin staining, which is denser.
The
The
smaller
smaller
one.
one is dense.
Smaller one.
Smaller one.
Smaller one.
Deeply basophilic.
And when you compare the smaller one to say this red cell, which is bigger?
Red cell.
Red cell.
The red cell.
Red cell.
So this is your small lymphocyte. Actually, I'm showing you in a wrong area because I could only get this when I was hunting. So let me see if I get something better in a more thinner area where morphology is better. Yep. So this versus this. Okay. So in this case, we won't call it hematogon because it's full of blasts. But otherwise, if this were a few percentage of cells, then it would be better to call them as hematogon. And this is larger than this. And this is your small lymphocyte. A small lymphocyte most of the time will fit easily into a red cell. So we use the small lymphocyte as a reference for microcytosis, and between lymphocyte and the hematogon, you use the red cell the other way around, the relationship. Okay. So it's a way to get to know what is hematogon, what is not. So generally, most of the people end up counting the hematogon as lymphocytes. It may not, make major difference in many occasions based on the diagnosis, but in a leukemia case like this, if you count those more slightly larger cell as lymphocytes, you will underestimate the blast count. Because this is a cancer, it is going to spread everywhere, occupy everything. So normal cells will be very few in this. Most of those larger cells are actually part of this blast population. Yeah, with this, we will go into the myeloperoxidase of the stain. So this is the myeloperoxidase stain. So first we will go into the control. So we saw those larger cells in between, which we thought were looking like promyelocytes. Okay.
Sir, we have a question.
So we have,
a question. Someone is asking Ritu how to differentiate blast and hematogon.
So blast and hematogone, that is why you look at the overall picture before. In this case, though there are cells which look like hematogone, but the overall picture is of a blast. So in this case, you will count them as blast. There will be other cases where I will show you how we differentiate, so that we will come to in the next, maybe after 2-3 slides, we'll come into that. So this is your myeloperoxidase, which is showing those promyelocytes. Okay. And most of the cells are negative. So the lymphoid blast can be very small. So that is one thing which you have to understand. So since the lymphoid blast can be very small, sometimes we can erroneously end up counting them as lymphocytes. So one of the dictums I use is, I only look for a small lymphocyte, use that as a reference, and put anything bigger than that into your blast, because basically your normal cells will get reduced whenever there is a malignancy. Like in this, see, there is a small lymphocyte, and look at how small the small lymphocyte is. Okay, and look at the staining. It's more darkly stained chromatin than the other ones. And you are having, I was also trying to look at, so blasts can sometimes have a lot of variations in them in terms of size, shape, and all that. So what we call as a blast is going to be a little bit determined by the circumstances where we are in. Manu, you would like to add anything?
Yeah, to the question how to differentiate blast and hematogone, I believe if you are sort of putting a spotter for a single cell in a case of ALL, be a sort of acute lymphoblastic leukemia, that it might become very difficult, because they have they might have quite similar morphology. It's not a spotter there. You have to have an overall look of the smear, like Dr. Mani said. So it's the environment of the entire smear you have. It's not like an exam situation. You focus on a slide and don't move it and comment on it what cell it is. It has to be the overall scenario where you're looking into that cell, because the morphology in that case may not help in a given cell. It might look absolutely similar at times. That's it. Blast morphology obviously may vary a lot depending on what kind of leukemia you might be looking into. But as you see, most of the lymphoblastic leukemias have a very sort of uniformly homogeneous, partially opened up chromatin and hardly any cytoplasm. So that's the look you have there of most of these cells. And that is somewhat different in morphology from acute myeloid leukemia in chromatin cell and size and presence or absence of nucleoli generally. Right. That's it.
Okay, I think, yeah, I was just taking a minute to see if I am able to hunt out any of those monocytic kind of cells which we saw there earlier, but I've been a little unsuccessful in that. So next case again. There's a lot of junk, I think, stain deposits which have come on this smear, but I'll try to take a good area. Sorry. So this is the next case. So I think Varshita can take this. So this is again a 10x view.
Yes. The lymphocytes are
Okay.
mildly elevated, but not as much as the previous slide.
Yeah. And what is are they all looking similar, or there is variation in size, shape?
There's variation, sir. I can see some are neutrophils and some are looking more like lymphocytes.
Yeah, at this favor, yeah, it might be difficult to appreciate whether they are neutrophils or not, but yeah, I do agree that what do you see here?
So the white cells are blood cells are large or cells we're seeing.
Okay. So we will go a little bit faster in this case. So you are seeing larger cells. So what would you describe this kind of cell as?
A large cell with convoluted nucleus and the cytoplasm is showing vacuolation.
And there are some fine granules, but they are not densely packed. They are very sparse granulation is there. Okay.
Yes, sir.
So you are having some of them are like some of them are showing you vacuolations. Okay.
Yes, sir.
Like this. But the chromatin texture, if you look at it, the texture is more or less uniform most throughout the nucleus. Okay.
Uniform.
Yes, sir.
So you pick any cell, any of those large cells, all of them, the chromatin texture looks uniform. So what do you call this kind of chromatin texture, which I had said? So people use various words. Okay. So there are some of them showing you nucleoli also 1, 2, 3. Okay. 1, 2, 3, 4, multiple nucleoli also. Okay. So most of these cells, in between you have some classical blast promyelocyte kind of a cell also. But predominant cell is this. But in this, if you look at the indentation of the nucleus, they are not very, they are very coarse. They are not like highly indented like you see in a mature monocyte. Okay. So these are the ones which we call as promonocytes. Okay. So this, the next thing we will look, once we see this is, let us look at what is a myeloperoxidase. So myeloperoxidase internal control has worked, but these cells are
Negative.
negative.
Negative for NPO.
Yeah. The last is this is a special stain. So what is the kind of special stain you would use in this? I don't know whether it has faded or not, so I'll just see. What special stain you would like to use in these circumstances? Any of you?
NSC.
NSC.
Yeah. So this is a alpha esterase. So if you see, there is nice staining in this. Okay. Some of this is less, but in many of them, see, like in this, there's a very good staining of this. The brown staining here is what we would call as alpha naphthyl esterase. So so this is a hematoxylin counter stain. Okay. Whereas your myeloid series cells won't be showing you that stain. Okay. So the stain has to be seen within a day or two. This is a recent one, that's why you're able to see. If you keep it for long, it gets faded. Next, I think as a last, I'll just take up one normal marrow as a last. So marrow, we see a little bit, it's like peripheral smear, but we see a little bit differently from. So initially we scan the marrow at 10x. So what do you see here?
A particle.
Narrow.
Yeah. Particle with the holes which you see in them. I will bring it down. Yeah. So in these holes are not fat spaces because they are outside the particle. This blue area is what is the particle. Inside that it's a three-dimensional structure. So when I move up and down, you will get various planes focused. So they have these holes in it, and this three-dimensional structure, inside this blue, the holes, that is what is called as the fat space. These are like when the fat cells lyse, they release fat globules, so they will create these kind of artifactual spaces. So you are not supposed to count these as fat spaces. The ones which are lined by this blue, dark blue basement material, that's what you count as a fat space. Okay. So this is having a reasonably good cellularity. Maybe I would put it somewhere around 70 to 80% cellularity. And when you look at it in low power, you are able to make some very large cells like this. Okay. And so this is again a very large cell. So these are the ones which we call in 10x. We try to look at this megakaryocytes.
Megakaryocytes.
Yeah. So in this, there's a particle, megakaryocyte, looks adequate. There are ample number of it. And then generally when you do your counts, you try to count on a trail. So this particle, okay. So this particle, when I trace it, there is a long trail in this of cells. So you do your differential count on these trials. in the peripheral smear, we used to do it in the zone of morphology. Okay, these areas, these trails is what you would use as a for doing your counts. These trails you will use for doing the count. So here also your aim will be to see in an area where there is reasonably good spread of RBCs. So you will see, so this I am just showing for the sake of showing what is the hematogone. So in the circumstances you are seeing, say if I put it in 20th, yeah, you are seeing a varying proportion of various cells. So you have lymphoid cells like this, okay, and you are having myeloid series like here. So all of them are mixed. Then there are few erythroid. So in these circumstances is where you would tend to call a similar morphology cell as a hematogone. So here you will get, so first we have to hunt out a small lymphocyte for us. Otherwise we use the red cell as your proportion measure. So here you are having two lymphoid cells. Both of them, when you compare with the adjacent RBCs, are slightly bigger or slightly bigger than the RBC. So these will go more in favor of a hematogone. So yeah, finally got it. So here if you start looking at this is smaller than, so this is your small lymphocyte for reference. Okay, and if you look at the other cells, the small lymphocytes, so if you go back you will start getting bigger cells.
If I can jump in, I think
yeah, sure.
The small lymphocyte is probably the best referral cell for describing any cell. So like Mani has already pointed many times. So it's say around 7, 8, 9 microns, that size. And you can actually put lymphocyte in the largest diameter of any cell, abnormal or normal, you are describing. So if you can fit in 3 lymphocytes in the largest diameter of an abnormal blast, you say it's 3 times the size of a small mature lymphocyte. In 4 times or 5 times or 1.5, 2.5. So that is the range you describe as a reference of small lymphocytes. That's the best cell. It has to be a non-reactive looking small cell, because lymphocytes can vary if they are reactive and larger. So best is to choose a small mature appearing lymphocyte, and then you compare any cell you describe with it. Just put it in the diameter, how many you can fit it in the largest diameter of that cell, and that's 2 times, 3 times. Done.
Yeah, I think I'll take a couple of minutes more. I think I've already overshot the time by quite a bit. So this is your eosinophil and core granules.
Mani, I'll have to quit, and there's a little sort of urgency.
I understand. So
please excuse me and apologize to the. Thank you.
No
so
issue, sir.
This is the coarse granule of the eosinophils.
It's a question in the chat box. Normal count of megakaryocytes in bone marrow smear, and how many are adequate?
So there is no clear guideline, no accepted criteria. What I use is what is pulled out from the biopsy criteria, where you say that 1 megakaryocyte per space has to be there. So I have just used it as 1 megakaryocyte per particle because each particle is from one space. So if you are having less than 1 megakaryocyte per particle, then you call it as megakaryocyte is reduced. Megakaryocyte increase is very subjective. But generally when it is increased, everybody will agree that it is increased.
Okay, sir. Thank you, sir.
I think with this, I think I will end. So I have tried to cover experience failed to appreciate megaloblastic change. So in this, if you see, the cytoplasm is very nearly
Sir,
hemoglobinized.
sir, excuse me, sir. Sir,
Yeah.
your slide is unshared again. It become you need to share it again, sir. Sir, your screen is not here.
Yeah.
So now. Perfect.
So is this now? So there are two erythroid cells. You are saying erythroid because centrally placed around nucleus with cytoplasm all around. Okay, that's the characteristic of any erythroid. Only thing is in this, the cytoplasm has nearly hemoglobinized and is very close to a mature red cell. So in this, hemoglobinization is more, but the nucleus should have become pycnotic and small at this stage. So this is in the intermediate normoblast is when late normoblast, sorry, not intermediate, late normoblast stage is when you are able to make out the megaloblastic change very easily. So many times I have seen my registrars miss this. So this is one of the things which you will have to learn to appreciate over time. Okay. Yep. I think with that, I will end today's program. So I thank all the students who have participated in this actively. And I think I managed to reach very close to what I had set out to try to do in this talk. Yeah. Maybe there are portions of it which we have not covered, but that's okay. That will come with experience. But basic stuff we have covered it.
Yes, sir.
Thank you, sir.